Thursday again, and I'm Naomi Morton, the infant feeding team midwife, and
I'm Alex, another infant feeding team midwife, and I'm going to put the lights on if that's all right.
Yeah,
it's really dark.
Yeah, it's a bit bright. We're sort of moving rooms again, and today we are on level 5 in one of the side rooms, which has got an ensuite and a fridge and everything in it. That's better. Tell us if you can see us okay. It's very bright outside, so hopefully you'll see what we're doing. Let us know if you can hear us, and today we'd just like to have some questions from you. Any questions at all that you think are for infant feeding? That's if you're pregnant, or if you've had a baby, or you're thinking about breastfeeding and you're not pregnant, it's absolutely fine. Just anything you'd like to talk about. Throw the questions to us. Let us know if you can hear us and see us, and that and make sure that everybody is tuned in.
I can see the user numbers.
I think we have got a few, haven't we?
We're at 16.
Yeah, absolutely. So hopefully it'll all catch up with us in a moment. So what we thought we'd first talk about today, just to get started, is if you're not quite making enough milk. So we have talked about how to make milk, and we've talked about how to feed, and we've talked about skin to skin, and about the 4 reliable signs of milk transfer, so that you can tell whether your baby's getting enough milk. But what do you do if your baby doesn't get enough milk? So how do we manage that when you go to have your baby's check on day 5 and the weight loss is a little bit more than you expected, or you get your baby weighed subsequently and he or she hasn't actually gained very much? And that's quite alarming for some parents, because they think they're doing really well and they are on track, and then suddenly they have their sort of confidence knocked because their baby's suddenly not gaining enough weight and they thought they were doing really well. So if you've got questions about that, do call us. So the first thing is to look at the 4 reliable signs and make sure that that is absolutely what the problem is. So we talk about whether babies are transferring milk and when they are nutritively feeding. So when babies go to the breast, we hear them swallowing actively, which is that after each swallow or after second or third swallow. So you hear that frequent removal of milk, but also you see the baby has got nice long deep glugging actions, so that you can see that they're actually transferring the milk really effectively at the breast. We don't want to be seeing the chomp 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 chomp, and they're not swallowing very much, and that will tell you quite a lot about how much milk the baby is transferring. And sometimes that's because of milk production, and then sometimes your babies aren't gaining weight because they're very sleepy at the breast, and that might be that they have a transfer of milk problem, so they can't actually get the milk out of the breast, and that might be that they've just got a bit of an immature suckle. They might have been a little bit premature, they might be a little bit sleepy, they might have had a very much more an instrumental birth, and sometimes, and very rarely, it's an absorption problem. So there's 3 different reasons why some babies, and mostly it's because mums haven't got their babies on the breast far enough and it's not deep enough. And so you really, really have to look at positioning and attachment always. That's the first thing that we always go back to. And when we see mums in the clinic, when they come to see us with problems, we always address, no matter what they've come for, we address the positioning and attachment first, because a lot of mums say, well, everybody's looked at the baby's attachment and they say it's all fine, and yet there's, people go back to default a lot. When they've had lots of help, they go back to what they remembered they were doing when they were tired, and then they slip back into what they were doing. So you have to be reminded several times, and been seen quite often several times, to reinforce the deeper latch, or the different hold, or anything about the way that the feeding's going, that you don't go back to what you came with. So that's the first thing that we would always look at, to make sure that the attachment is absolutely right. And millimetres on breastfeeding is the difference between several hundred grams a week and not enough weight. And sometimes it's absolutely transformational, just tweaking that baby and getting the really good position. And a few weeks ago we did some positioning with mum with babies at the breast, and we talked about the way that the baby goes to the breast from underneath or straight on, depending on how your breast falls. And that's probably the most common cause of babies not gaining weight, is that they're actually not on the breast deeply enough or quite in the right place. Even if you haven't got pain, sometimes you've been doing it for a while and you've got used to that discomfort, but actually when we tweak it, the mum might say, well, that feels better, and it is more comfortable, but she hadn't realised that it was slightly uncomfortable before, and it can make a big difference. So that's always the first thing that we would look at. You got anything else to add on positioning and things like that?
No, I think not at the moment. We've got a few questions coming through as well.
Yeah, and mechanically, we would look at tongue function, and but the first thing we would always look at, even if it was tongue function, is to look at the positioning and attachment, because if the attachment isn't quite right, and we get a lot of questions on tongue tie. People are always hung up on tongue tie because it's it is a cause and source of discussion for many mothers all over the world, and I think that if the tongue has never been able to be used properly, it can't do what it's supposed to do. So good feeding is good physio for a tongue, and a baby in the early days is only just learning to use its mouth. So if you start changing things in the very early days, it hasn't learnt to do what it was supposed to do in the first place if the feeding isn't tip-top to start with. So it's about really being sure that that feeding is good, going away and then practicing what we're doing for a few days, and then come back if it's still worse. But actually, I'd say if we saw 100 mothers in clinic with tongue ties, 90 of those would not need anything else doing to them. We would just increase the positioning and attachment, improve the latch, improve the baby's gape, get more breast in the right place in the baby's mouth, and then the tongue function will start to improve, and the baby will then start to transfer milk, and then you'll start to see the 4 reliable signs come to you. You're suckling, you're swallowing, your baby's peeing more. Oh, the baby's nappies are really full. There's lots of yellow poo in there. They were green last week. And then the last thing is, which you don't need a pair of scales if those 3 things are good, but the last thing is, if your baby hasn't been gaining weight, is you see the weight start to change. And the thing about breastfeeding is that it takes 48 hours to see any change when you're talking about breastfeeding. When you're talking about milk production, it doesn't happen that next feed, it doesn't happen that next morning, it doesn't happen at the end of the day, it's after 48 hours at least. So when you're looking at all the pumping and everything else that you do to increase your milk supply, which we'll come to in a moment, we'll answer a few questions, I think, first.
We've got quite a few piling up at the moment, and I'm struggling to get back to them.
So, it's about getting that positioning absolutely right. Your baby is a new dance partner with you, and you've got to learn to dance together. And once you start dancing well together, then things start to go well. But it does take practice, and it is a skill that you have to learn, and having guided support is really important if you're struggling. So that's the reasons why babies don't gain weight. It's not just about positioning, it's not just about the baby having a tongue tie, it's lots of different things coming from different places. So bear that in mind, and if if anything's going on there that rings true to you, then fire the questions at us if you need to. Okay, questions.
Right, I'm trying to get back to them because I actually can't wait. We had a bit of a technology issue last week.
We did, so we don't touch the screen anymore.
We don't really want to touch the screen, so I know there were more questions here, and I can't get back to them.
Well, let's start with the other ones first.
So I've got Marianne, who's asked that she's recently had a 34-week check in Bicester. She thinks the baby is foot breech. We'll find out for definite next week. A 36-week scan. Are there restrictions still in place that mean my husband won't be able to be with me at the scan? Yes, there are. We are still one person at scan at the moment.
Sadly.
And about 2 hours after the scan, I also have an appointment with a consultant at the JR because my last birth left me needing a blood transfusion. Is my husband allowed to attend me with this? It is just the women at the moment. All appointments are just women. Lastly, if the baby's definitely breech, are there any particular days that you offer ECV? Is my husband allowed to attend this with me? I completely understand the reasons for restrictions, just feeling a bit overwhelmed. At the moment it is just partners, it hasn't been extended to any, it is just the mothers, and it hasn't been extended to partners for any visits within the hospital. At the moment it is just still birth and for an hour afterwards that partners are with you, I'm afraid.
For some of the sessions that we've done, we've had the partners on a phone in the room, and they have been part of the conversation and have been included in questions, and everything else. So it may be that the person you see is happy for your partner to be involved on the telephone, or to be able to see and hear what's happening, and it's with the conversation with the person that you're seeing in the clinic or the scan. That might well be something that they're happy to do.
Okay, we've got quite a few here, and I'm going to have to go over to the screen, I think, to pick up some of the older ones. Sarah's asked, said she's got 20 weeks, she's 20 weeks on Monday, and her employer's asking for the MAP-B1 form. The doctors aren't doing these currently. What's the easiest way to go about getting this? Ask your midwife, give them a call. We have the Ask the Midwife number as well, so if there's any concerns getting hold of your midwife, you could try them. It's available on the MVP. You can go onto the website, the hospital website, and the number for the Ask the Midwife number is there, so they'll be able to instruct you. But usually it's your midwife that gives you your MAP-B1. So contact your midwife, so they will be able to get it to you somewhere.
And you can have that from 13 weeks when you're pregnant. It's from 13 weeks, so you will absolutely be able to collect it. And if you give her your details, she will have it ready for you if you need to pick it up.
And I'm very aware that there are questions that were asked previously. We will go back to them. I'm really sorry about this. We're doing this a bit round the other way. So Stacey's asked, how long do newborn babies breastfeed for? And then she's also asked us a second question, would you like to give birth on the spas? Do I have to book in beforehand, or is it just there if it's available? It's a case of coming in and saying you want a spas birth, and that's absolutely fine, as long as you meet the criteria, and they've got the availability on the spas unit. You can have a spas birth. It's the availability that would be crucial. But with regard to how long does a baby feed for, well, we always say between 5 and 40 minutes. So we anticipate a baby will feed for 5 to 40 minutes on one side, and then you would offer the second, and it's always offering the second breast. Babies won't always want it. It's a bit like when you go out for a meal and you have a main course and you decide you'll have a pudding. So your baby may want pudding sometimes and may not want it others, but it's always nice to be offered. So do always offer your baby the pudding of the second side. So that's that one. I can see them all coming, and I'm so sorry to the ladies who put their questions in first. Rita said, I understand why partners can't be there at the appointments and scans. Why can we not have a video call when the scan is performed? I think that's because when the scans are going on, it is quite what's the word I want to use? It's quite a very important part of your care. And it's the person running the scan has to really, really concentrate. They have to do a lot of figures, they do a lot of measurements, they are checking the well-being of your baby, and that is why usually they will not really want you to be using a video call at the same time.
It's very dark in there.
It is also extremely dark in there for them to be able to see. So from that point of view, that's why they wouldn't normally. If you're coming to one of the appointments with us as an infant feeding, then we're more than happy to have that. But it's a very different situation. But it is a very, very important part of your screening. And I think a video, is considered, might be disruptive, might be
distracting.
Distracting is the word I wanted for the person.
So you want them to do a really good job when they're looking, and not to be distracted by things. So at the moment, that's not something that we offer.
Right, I'm going to go back again, see if we might have to go to the screen. We've got Madison's asked that she'd like to combination feed. Should I exclusively breastfeed for a certain amount of time before moving to combination feeding, or can I start from day one? Is there anything I can do to make combination feeding easier for the baby to adjust to? Do you want to answer that?
I think the answer is that it's your baby, and you're perfectly able to do whatever suits you as a family. It's your decision in everything that you do, looking after your baby. And so if it's right for you and your family unit, then that's absolutely okay to do that. Especially if you're thinking of going back to work very quickly, or having to do other things, or you've got lots of other stuff going around. This is something that lots of mums choose to do, and it works very well for some families. I think that if you want to establish breastfeeding and breastfeed well, we wouldn't suggest that you start supplementing your baby before about 6 weeks, so that you enable your baby to establish the milk supply. And that's your calibration period, when you start to make the right amount of milk and your baby starts to ask for what it needs. if you start from the very beginning and you're going to continue doing that, so from the first week or whatever, and that's your choice, then what will happen is your milk won't be made when you give those bottles. So you will have enough milk for what your requirements are, but it may be that you can't make any more, and you've got a very small window of about 3 to 2 weeks, 3 days to 2 weeks, where you can start to calibrate your milk supply, and your prolactin receptors in your breasts are plugged into your brain, and not literally, but that's how we see it, that we plug everything in and start to kickstart it when your baby's born. And so if you calibrate for those feeds for the first 3 to 14 days, that supply is what you will make. So if you start introducing bottles in that time, the supply that you make will always just be what you've asked it to do. So if you then change your mind and say, well, actually, I would like to feed a bit more, it's unlikely that you will be able to increase your milk supply easily. Some women can, many women can't, and we see many women in clinics that haven't done lots and lots of early stimulation for various reasons. They haven't been told sometimes. And so the milk supply is low, and it's really, really hard to get that milk supply back up. So if you're wanting to breastfeed but then later on introduce a bottle because you're going to work, or you've got other commitments that you're wanting to do, or your partner wants to be more involved, you have choice if you do the really sort of early feeding and frequent feeding and offering, for the first 6 weeks, you have choice. You can give both. And if you want to give more breast milk, you've got the choice to give more because you've made it. If you want to give less, that's fine. Your breast will then, if you start pumping again, will start to make more again because they've already got that order in place and it's embedded. So it depends what you want and whether that's what you're going to do the whole time, or whether some days you want to breastfeed lots more and give bottles other times. It's entirely up to you what you do. It's your decision. But if you understand the way that breastfeeding works, stimulating your prolactin receptors, switching those all on, protecting your milk supply will ensure that whatever you want to do, you will always get that milk back or have enough milk to give your baby once you have decided to start introducing bottles. So some people say introduce a bottle once a week so your baby knows how to take a bottle, but actually it's very individual for the baby, and it's entirely up to you what you want to do. Remember that partners can do an awful lot of other things other than feed a baby. There's lots and lots of things that they can help you with. They can make you tea, they can shop, they can cook supper with you, they can change the baby's nappy, they can settle the baby after a feed, they can change the baby while you're sleeping and then wake you up for a breastfeed, and there's lots of things they can do without actually physically giving your baby a bottle. So they're not going to miss out if they don't do that in the early days. They can do so many other things with lots and lots of skin to skin and cuddles and still get that relationship with the baby. So it's entirely up to you is the answer. It really is your choice, and when you introduce a bottle of formula is entirely up to you. But bear in mind that if you want to make sure that you've got enough milk, you have to stimulate and switch everything on. And once you've done that, then you've got that secure, and you can then make choices yourself afterwards, and you can go backwards and forwards with whatever you choose to do if that's how you're going to play it. Does that answer your question, I hope?
Yep, so I can see that our wonderful colleagues at Hayley's on at OMVP as well. She's put up as well about what we were chatting about with the scans, and that it is the guidance of the sonographers.
Thank you.
I'm afraid it is guidance, and because it's screening, it is very important that the sonographer is not distracted. Anyway, Shannon, I'm going to do Shannon's question, and I'm going to see if we can go back to some of the ones that were right at the beginning. Shannon, she had a 36-week midwife appointment last week, and the midwife felt the baby was slightly concerned. The baby was on the oblique position. And then her 36-week scan 4 days later, and the midwife carrying out the scan said the baby was now head down in the right position. Will my baby stay in the right position now, or is it possible she may move back to the oblique? Just worried, as I understand, if she was oblique, it could cause issues with the cord if the waters were to break. Well, I can talk very honestly about this one because I've been there too with babies that move all over the place. They do move around. It depends on whether it's your first baby or not. First babies tend to go head down and stay head down when they get there. Subsequent babies have a habit of moving about. So, you know, by all means, just keep getting someone to check where that baby is and have a look and see. You know, if you've got any concerns, you can contact the midwives, and I'm sure they'll be more than happy to check where your baby is. So just, you know, keep going. The likelihood, though, if it is your first baby, it's probably now head down, and it will probably stay head down. As I say, subsequent babies have a habit of moving about. So you could always contact MAU and ask them if they would be prepared to check the baby if you look like you're going into labour. So I hope that answers your question.
I'm just trying to see if I can get the questions up, but I can't.
I can't go back, so I'm just going to go back. I'm going to come towards the screen and just go back again. So bear with me, everybody. You have to see me quite close when I go back. See if I can go back to the other questions. Right. So we're some right at the beginning that we missed.
Was that
We've got Aya.
Regina, who was on a pathway D at my 20-week scan and needed a GTT2. Should I make an appointment with my midwife and or the GP if the midwife could tell me which number to phone? Abingdon office is closed and I can't get through to Wantage. Okay, so that would be the maternity support line, will it be, to get
Ask
that?
the midwife. But
Ask the midwife.
Wantage are open. I've been speaking to Wantage today, so they are open. Do keep trying them. So that office is open. There are people in there working today. So do try. Hopefully get the answer phone if you don't get a person. Leave them a message. I'm sure they'll get back to you as soon as possible. You could also try the Ask the Midwife line. We've got midwives there who are taking calls, and I'm sure if need be they could always send an email to the Wantage team if you haven't been able to get through. We've got another question up here that was one of the early ones, and it was Aya, and she'd heard a lot about expressing colostrum before birth and collecting it. Is it very useful? Is it necessary? Not necessary, not particularly. So, but it can be useful. Some mums like to do it. It's a skill that you've learned early on, and that it allows you to master that skill before you've had your baby and have a little bit of something as a backup once the baby is born.
If you go back to our previous sessions, this is our 6th one now. We did spend quite a lot of time talking about colostrum harvesting and antenatal hand expressing. So you might want to refresh yourself on that, because we did spend quite a lot of time doing that, as well as what Alex has already said. And just think, you don't have to do it, but you might want to learn how to do it. So you might want to have a go in the shower, and that's it. You've got it, you see that you've got the skill, and that's absolutely fine. Or you might want to collect a little bit for your baby, that's absolutely fine. But actually make sure that you're 37 weeks plus, so that you don't tip yourself into labour if you're ready to go and you're just a bit niggly. We don't want to have you having your baby too early if you do too much hand expressing, and the risk is very low, but I think some mothers have said that it has made them go into labour, and they have found that. But we recommend that you can talk to your midwife about it from 36 weeks, and then you can start harvesting colostrum at about 37 weeks. And if you've got any medical problems, so if you're, gestational diabetic, or you're on any medications, or you've got any medical problems where you think your baby might be needing a bit more support, then it might be a useful skill for you to have, so that you can collect some colostrum before you have your baby.
Okay. Let's have another look. The Association of Breastfeeding Mothers have some information about hand expressing as well, which is useful. So Sian has asked, how are the home visits happening, or are they happening? She's due on Saturday. Good luck. They are happening.
I think they're doing very minimal home visits, and they're trying to get everybody to come into a specific area, so it depends which part of the county you're living in. If you're in Oxford, then you probably will come into the John Radcliffe if you're on Blenheim team. Sometimes the ISIS midwives will see you at the John Radcliffe, sometimes they'll see you at Flo's Children's Centre. And I think that they are now seeing you the day after you go home. So they will invite you to come into wherever they want you to be, unless you specifically cannot physically get there because of your circumstances, then they may consider home visits. But actually it is the best, safest way for us to work as midwives is to have us in our environment, and you come into that. And we are wearing protective equipment. that we've got masks, goggles, pinnies and gloves on for face-to-face contact. Anything else that may create any worries. So if you're in labour, then we wear slightly more PPE when we're working with you in labour. But whatever happens, you will be met with us with masks and goggles and gloves and a pinny on as well. And we change those between each person that we see, and it's much easier for us to manage that if you come into our environment than going into people's houses. It's much lower risk for everybody. So I'm afraid we are inviting you in, and that has been the practice that we've done for quite a long time for most of our visits anyway, even before we had COVID pandemic.
So I think the answer to that is really that yes, you will have contact with us, and you will have, so as Naomi says, it's day 1, and then normally it's day 5, because on day 5 the babies are weighed and the heel prick test is done, which again is more screening, and then day 10, assuming the weight was fine on day 5. So the normal contact times will be day 1, day 5 and day 10. Or I say day 1, it's day 1 at home, it's not day 1 specifically, it's the day that first day full day you're at home, the midwives will make contact with you. And if there are feeding problems going on, they will put feeding plans in place and support is provided. And if it's necessary, then you get put in touch with us. We don't see everybody though, we see those that need to see us. So, you know, the majority of the women out there who may encounter a few problems in the first few days, all our staff are really well trained and very good at giving early days breastfeeding support and keeping mothers going. It's only those that perhaps need a bit more support would then get involved with us. But you know, so there's different levels of support available to you.
And I think, you know, time, because you can arrange when you come and see your midwife rather than waiting in for the midwife to come, you can arrange to come in to see the midwife when your baby's hungry, and then she can hopefully help you with some breastfeeding support as well at the same time if your baby's ready for a feed. So if you can try and time it, if you're having worries with a feed, they can then support you to breastfeed when you arrive as well, and that can be very helpful if you're struggling a little bit.
Just going to see if we missed any more of the earlier ones. I can see some new ones coming through. So that we talked about expressing, and home visits we've covered. Nope, we're up to date. So we've had, I'm checking on the computer over here as well. So Marianne's asked, thanked us for answering her question, but also asked if the ECV appointments are on specific days. I believe they are. There's an ECV clinic. I have to be honest and say I
think it's a Monday or a Tuesday, but it might have changed with the circumstances that we were in. And if you are booked into that, then they will tell you what day it is. And it depends on the availability of the midwives as well, with the situation that we're in, as to the shifts that they're working and when they're free and able to accommodate you. So there will be clinics every week, but I'm not sure what day it is at the moment. But they will tell you if you need an appointment. They will offer you that appointment.
Yeah. We've got another question, so I think we're up to date now. Oh, Rena's come back, and she wants to say that the midwives at the JR are amazing. Thank you, Rena.
They are, aren't they?
From birthing on my own to my daughter becoming poorly and needing NICU support, if you have any doubts in regard to care, support, or compassionate experience, I can on my heart assure you there is no worry. My daughter would not be here if it wasn't for the ladies on level 5. That's lovely, and we'll relay that to our colleagues, because we're actually on level 5 doing this today. So when we go out, we're going to say that from Rena. That's so lovely to hear from you. Thank you, Rena. We love feedback. Rachel has said, is there any recommendations the type of dairy you should eat when breastfeeding? Is it true that higher fat dairy, i.e. semi-skimmed milk, is better for breastfeeding than skimmed, for example? Do you want to answer that one?
I think you can eat pretty much what you like and drink pretty much what you like, and just eat what your preference is and what you normally eat. You don't need to do anything specific. You know, we need about 500 more calories when we breastfeed. You don't need to eat, for a whole football team. You can just increase a little bit. And the thing is that you'll feel hungry. You will feel hungry and you'll feel extremely thirsty, and you need to drink. And we talk to mums about how much they need to produce in a 24-hour period, and it's a lot more than you think. It's about 750 mils and some up to a litre a day. And certainly, you know, if babies are in the neonatal unit, they like mothers to be able to produce large volumes by day 10. So, you know, up to a litre by day 10 a day which then secures their supply for long-term feeding if their babies are in the neonatal unit for a long time. And so it's you need to produce lots of fluid, so you need to replace that. So we say eat when you're hungry and drink when you're thirsty, and then your body is regulating itself, and when it's hot your baby will want more food and so will you, or more drink. And you don't need to give any water to babies if it's warm outside. We're having a lovely spell of lovely weather, so babies will probably be more thirsty, and you might find that they step up their breastfeeding on these hot days, and then the next day or the day after you find that your breasts are quite full and your baby's very happy and glugging away, and there's lots more wet and dirty nappies, and then that settles down, and then they will up their game again if it gets hot again, just as you will want to drink more. So you know, it's common sense really. Just look at what's going on around you. Are you eating enough? Are you fitting in enough food in the day? Because actually it can be lunchtime before you've even sort of got out your pyjamas when you have your first baby. So you know,
and that's not a problem.
You miss. That's absolutely fine. We love to see mothers in pyjamas. That means that you're doing what you should be doing, which is not going out and running about, which obviously you can't do the same at the moment. But you know, being at home is really important. But also, somebody gave me a really good tip when I had my first baby, and they said, know what you're having for supper at 9 o'clock in the morning. So you cook your supper at 9 o'clock in the morning when you're just feeling a little bit less fatigued than you are at 7 o'clock at night when you've got to think about feeding the family. Know what you're having at 9 a.m. and make it and put it in the fridge, and then you've done it. So that life is a bit easier,
unless
so that you're eating properly, unless you've got someone else to do it for you, and then somebody rings up and say, can I help? Yes please, make me supper.
Bring a meal.
Put it on the doorstep.
Yeah, absolutely.
So you know, don't overeat, because you don't need to. You'll probably regret it when you've given up and you're you know, going back to work and all those things, and you've got an extra inch around your tummy because you enjoyed everything. You don't need to eat extra food. You don't need extra fat if you don't normally have extra fat. Just eat what you normally eat with a little bit extra, and then you'll make exactly what you need to for your baby.
I think it's thinking about, you know, if you think the world over, women breastfeed in all regions of the world, and we have completely and utterly varied diets, and yet our babies will thrive. So from that point of view, there are huge portions of the world that don't eat any dairy at all, because it doesn't feature in their diet. So, you know, it is just eating a sensible, reasonably well balanced diet. You know, there are no forbidden foods, as I used to tell my antenatal groups when I used to teach antenatal classes. There are no forbidden foods. You can eat what you want. So,
and that includes garlic and chilies and spices and
you hear about wonderful
whatever
things.
You want to
I've got told you couldn't eat strawberries. That's not true. You can eat whatever you want. There really are no forbidden foods. You can eat whatever you want. So.
Well, the caffeine does sometimes affect. If it affects you, it does sometimes. Yeah. If you have too much, keep your baby awake a little bit as well. It can do a little bit. So, you know, maybe cut down your caffeine intake a little bit if your baby is very wakeful. It might be that that's what it is. But actually, sometimes that doesn't even affect babies either. It depends how sensitive you are to caffeine. So, you know, play it by ear. See what happens. You know, eat everything and enjoy it. But don't do it too much. Don't eat too much.
You don't need to be eating for two. To pump to collect colostrum before birth. We would suggest you do it by hand actually. Pumping, if you're using a pump, you tend to lose it in a pump. Colostrum is thick and gloopy, it's a bit like golden syrup, it gets stuck all around the pump and you lose it. So actually we would highly recommend that you use your hand. It's much more responsive, you get a better feel for what your breasts are like. It's a really good learning curve for your, you know, what your breasts feel like. And actually we get the best results with hand expressing. And it, you know, when we're dealing with mothers who maybe are a bit engorged on day 3, we'll always start with hand expressing, start getting those glimmers before we even think of a pump with those women as well. So actually hand expressing is fantastic. We treat it as your first aid, so we do try and ensure that every woman leaves this hospital knowing how to hand express, because if it's 3 in the morning and you can't get your baby to attach, if you can express a teaspoon worth of colostrum and get it into them, you've done a great job. That's going to keep them going until you get the help that you need with feeding. So hand expressing is really recommended for colostrum, unless you are one of the rare women who's producing lots. And some do, but the majority of people don't, and you lose it, which is a real shame. Rachel said thank you. So you go and eat what you want, Rachel. No restrictions. So, I think we've done our questions.
We're all caught up.
Yeah, we're all caught up. Unless someone's out there saying, "Oh, she hasn't answered my question."
We'll come back and ask us
apologies
again,
if
and we'll
we
see.
haven't.
We're not very good at this, are we? It's all technology. So we were talking about making enough milk, so we'll just talk a little bit more about that and the plan, the sort of plan that we might put in place when your baby isn't quite achieving what you want it to do, or what the midwife wants. So if you've got a little girl, we say about 20 grams a day, and a minimum, and if it's a little boy, about 30. So between 20 and 30 grams a day is the minimum requirement for your baby's weight gain, and that we expect them to do that until they're 4 months old. So if they're not quite gaining that, and we don't weigh babies too often because sometimes they don't gain weight for a few days and then suddenly they put on 200 grams and then and that you haven't done anything different. It's just that that baby's for some reason gained more weight. They've had perhaps a few more feeds or something. But so when we weigh babies, that is what we would expect. So in the first 5 days we don't weigh your baby, but we look at the 4 reliable signs of milk transfer, and we've talked about those lots and lots and lots. But actually in the first 5 days, if your baby isn't achieving what we think it should be doing, so peeing and pooing appropriately on day 3, so it's not having a poo on day 3, and it certainly hasn't pooed by day 4 in the morning, then you should be calling your midwives and saying, my baby is not pooing. Looking at the wheeze, your baby should have, 3 or 4 wet nappies on day 3, 4 on day 4, 5 day 5, 6 to 8 on day 6, 7 on onwards. So it goes up as the proportion of fluid that your baby gets goes up, and as your milk goes from colostrum to transitional milk on day 3 to mature milk on about day 5, the volume of milk goes up and the baby's output changes. So that we've talked about the changing poos, and it goes from that sticky meconium which sticks to the baby's bum to on day 2 to 3 it would be not so sticky and greeny brown, and then on day 4 to 5 it should be yellow. But if your baby's not pooing at all, it probably is an indicator that maybe there isn't enough colostrum going in, and maybe your milk has been a bit delayed coming in. You might have had a longer labour, or you might have had a blood transfusion, or a bit less skin to skin. Sometimes that delays the milk coming in a little bit. Then we would expect that your baby should still do those poos and wheeze as we expect. And if they're not, you need to talk to somebody before you get to day 5, because when you get to day 5, it's probably likely that your baby will have lost more than 10% or above, which is sort of our cut-off. We don't like babies to lose too much beyond 10%. So that's a really good indicator. Those 4 reliable signs of milk transfer, certainly the first 3, are really telling in those early days as to whether your baby is able to get enough fluids.
Should I get a postnatal care plan?
Yes, just behind you. Just behind you. It should be on the top there. I gave one. And so it's really important that you recognise that, so that you can get help before it becomes a problem. So you're not putting your sandbags out to stop the flood after it's happened. You want to be able to do something about it before. So become more proactive. And Alex will show you on there in your care plan.
I know we've showed this in weeks before, but this is a postnatal care plan that every woman, when she has her baby, is issued with, and it has an awful lot of really useful information, starting with the midwife's telephone numbers. It has a log about all the birth, so all about the information about the birth, including when the baby first breastfed, and all the sort of the really relevant information. And then we have a double-page spread where we do our daily checks. So daily checks on mum, daily checks on baby. And that includes what the poos and wees are doing, and how the baby is, and how the feeding's going. And then we have quite a few dedicated pages to feeding. So we have these 2 pages where you can log your feeds down. It's really useful to log them down, because those hours in the time after birth really blur. 5 hours can pass as in the equivalent of a half an hour really easily. So it's really good to write them down. Some people choose to use an app. For us, it's quite useful to have these because we can have a glance at them. And it gives you an idea of when did your baby last feed and how well did they feed. And there's a section at the top of this page here which talks about how well did that baby feed. So babies go through a process of feeding. They start with licking and learning what the breast is like, and eventually they lick and they start to root and try and attach. And then they attach and suck fairly weakly, and then they attach and suck really deeply. And that's 1, 2, 3 and 4 in our plan here. Licking and rooting, attaching weakly and attaching really well. Some babies go straight to 4 and that's fine, but others take a little process. And we see that happening here all the time. Babies that aren't attaching on day 0 and day 1, by day 2 and 3, they're doing brilliantly. So this is a great place to log it, and it gives you the opportunity to log all the poos and the wees of the baby, because that tells you, as Naomi said, whether that baby's getting food and transferring it well. And then on this section, I talked about the hand expressing. We sign off that we've taught you how to hand express here, and we sign off that somebody has watched you breastfeed. And then we put in any plans that need to put in place here. So we put in a plan here that might be lots of skin-to-skin contact because your baby's a little bit sleepy, not really going to the breast. So we might just put in there lots of skin-to-skin contact and hand expressing and getting that colostrum into the baby. And then it could be a bit more comprehensive, but that's predominantly what happens. And then this is a checklist which is always useful for everyone to look at, and it will cover everything that Naomi's just talked about with regard to the 4 reliable signs. It talks about what's that baby doing when it goes to the breast, what are the poos like and what are the wees like. And this is pre-72 hours and this is post-72 hours, so as you can see it changes, because the amount of baby takes in changes, what the poos are like changes, and the amount of wee goes up. So this is allowing for it, and this is a really good page for you to look at. And this will be, if you're in the hospital with us, this will be at the end of your bed, and it's there as a really useful resource for you. And it then goes home with you until you're discharged on day 10, usually about day 10, by the midwife. So it's there as a record of how things have started, how they've gone, and any help you may have needed along the way. So it's a really good resource there for you and for us, not just for us. So do use it.
And we encourage the staff in the hospital to write down the care that they give you every day in the care plans that we've just shown you in the little plan that we've got, so that when you go home, the community midwives can see what has been happening to you in the hospital. So they can read it and say, oh, I see you had a few problems in the early days, how's it going now? And they can compare what you were doing then to what you're doing now. And quite often babies feed really, really well at birth. They're primed to do that. They come out, they are really alert, and they will suckle. Even if it's been quite a complex, long, difficult labour, they may still be really alert at that feed and have a good feed, and then they don't feed very well at all for a couple of days. And that causes huge amounts of concern for parents in the fact that they can't get their baby to have anything, and it's just a question of skin to skin and waiting for that baby to just process what's happened, to wake up, pass lots of meconium, get the mucus out of their tummies that they have from the birth, and then they're ready to feel they're hungry and they're ready to eat. But in that time, you're doing your hand expressing, because then that's your stimulation, that's your priming your prolactin receptors, you're starting the process of making the milk, even if your baby's sleepy, and you're giving little and often, and it's that confidence that your baby doesn't need to have 70 mils of formula or breast milk even on day 0. You don't have that volume in your breast for a reason on day 0. Your baby doesn't need it. It's small, really concentrated, high calorific drops of colostrum. It's liquid gold, and that's the start of it. So that will start the process to stop your baby from losing too much weight, because you're starting the process of milk production, and your baby will start to wake up and start to show more interest. It's even more likely to do that if you've got it skin to skin and you're holding your baby with you rather than tucking it up in the cot in the corner of the room. That will, guarantee that your baby will sleep through a lot of cues. If it's had a long, difficult labour, it won't start to act out its cues for feeding. So, frequent skin to skin and frequent stimulation, the skin to skin will make the milk production go up, and the hand expressing will encourage that, and it will also enable you to give your baby some milk. So those are the first 5 days, and how much is enough wee in your nappy? A couple of tablespoons of water in a nappy, and feel how heavy it is. That will tell you on about day 4 or 5 how much wee your baby should be doing. The volume in the nappy should go up. You can hardly tell in some of these disposable nappies. They're really dry even when the baby's peed, and the only way you can tell is that it's changed the colour on the line, hasn't it? So you know, have a think about the weight of the nappy, and when you've got milk in your breast, then you should start to see heavier nappies come, and that's a good indicator for you to see that it's having enough, and that it's not just once a day. So you get to day 5 and the midwife says to you, well, your baby's lost 11.5%. And then she'll put a plan in place. And what she might say is that you might want to wake the baby and feed it a little bit more frequently. And that may well improve your milk production. It will improve your milk production, but also getting a good attachment. So you need to make sure that your baby's latched well onto the breast so that you can actually get milk out. So your baby's making the most of the small volumes that you have in your breast. It's making the most of it by actually being on the breast correctly, and that makes a big difference to your baby's transfer of milk. The other thing that you can do is compressions. Even when you've got low, colostrum milk in your breast, you can still compress. So you can do it with both hands, you can do it with one hand, you can do it like that. And basically when your baby is suckling, you compress. There's not pushing like this, you compress and hold, and you go as far back to your chest wall as you can so that you're not disturbing the nipple in the baby's mouth when it's suckling. And then that will allow more milk, more colostrum to be pushed into your baby's mouth more effectively, and it will also stimulate more milk production. It's like pumping while you're breastfeeding. It increases the milk production. So that's a really good way of getting more milk into your baby, but also increasing your milk supply too. So it's really important that you actually can stimulate your breasts early on to keep that going. And then, so that's the first thing that you do. You'd start making sure that the baby is attached well and that you're doing compressions to stimulate that milk production. And then that might be all you need to do at that point. That increase the feeds is the baby having 8 to 12 feeds in 24 hours. So it's not having 6 hours, 7 hours sleep at night, because that will miss out on several feeds and that baby's weight will go down. So are you feeding your baby frequently? So not regularly, frequently. And no more than 3 hours between the feeds. So that means that your baby can have a feed after 2 hours or 1 hour or 3 hours. But if your baby has lost a little bit more than 10%, then we would suggest that you feed your baby slightly more frequently and don't let it go beyond 3 hours between feeds, and that's day and night. So don't let it have a 6 hour sleep at night, although that's very attractive when you're tired.
Not good for your milk supply.
It's not good for your milk supply. It's not good for your baby. So you need to set your alarm clock if you've got a baby that doesn't like to wake up frequently at night, until we're sure that he's transferring milk well and you have got a good supply. And then when that happens, then you can turn all the clocks off and you can start to sleep and you can start to respond to your baby more. But that's the first thing that we would suggest you do. We've got a weight loss management plan, haven't we, that we use in the hospital. That shows
for it.
We have a sort of a guideline that we say that the staff use in the hospital, and it starts with plan 1, we go to plan 2 and then plan 3, and if it's low weight loss, so just a little bit more than we are anticipating, or a little, the baby's not feeding very well, then we would follow management plan 1, which is what I've just told you. And then management plan 2.
We're not going to expect you to be able to read it from there, but it is all set out.
Yes, so that so the next one might be that you pump after you've you might pump after every feed. So you might breastfeed your baby, and then you might do some sessions of pumping until you next see your midwife. So that might be 48 hours. We generally weigh babies every 48 hours if they're not gaining very much weight. We don't do it every day because you don't see change quick enough. So it might be then that we suggest that you do the compressions and the frequent feeding, and then you might add a little bit of pumping to it, so that you might have a session about half an hour after a breastfeed where you're pumping, and then you give your baby back food if necessary to just to top him up a little bit after some feeds. And you can do that by cup, you can do that by finger feeding if it's for short term, and you can do it by giving a bottle as well, and that can ensure that your baby gets enough food.
Right, that's our bleep, so I'm just going to go and answer the bleep. Emma has asked what you collect it in, so I'm going to leave Naomi with some things that you could collect it in. So this is colostrum. Emma's asked. I'll be back.
So that's the syringe, little tiny syringe. It's got a bung on the end. Okay, so that's good for colostrum. We don't recommend anybody gives their babies food beyond colostrum in a syringe, because your baby could aspirate. So, and that's a little pot that you can use as well, like that. You see. So and that's washable. And remember that anything that you have with breast milk or colostrum is soapy water. You wash with soapy water, and if you're using anything with formula in, you need to sterilise, and you need to have either a steam steriliser, a water steriliser, or whatever steriliser you've got to make sure that your feeds are, bottles and things are sterilised. And then management plan 3, we just step that up a little bit more. So babies won't be on that until they've lost certainly more than 12.5%. So you would probably get involved. A midwife may well call us and talk to us about a plan put in place and run it through us, and then we'll decide if your baby needs to be seen by anybody, whether we need to see it or whether your baby needs to come into hospital, depending on how it's showing signs. So it's really important that that you are able to actually produce more milk, to get that milk production going. And certainly the first thing is compressing. The other thing that we talk about is switch feeding. So even in the management plan 1, which is when your baby has lost just 10% or just a bit below, and it's not feeding as well as we'd like it to. Maybe it hasn't had a poo for a bit, or your baby's poo hasn't changed to quite yellow on day 5, so it might be a little bit browny still. We want to push a little bit more milk in. Then you can do some switch feeding, and I think we have talked about this before, but you can let your baby suckle at one breast, and when your baby falls asleep, which I think is what a lot of babies do that aren't transferring very much milk, because they are very much driven by flow. So if the flow is very low in the milk, so they're not getting lots of mouthfuls, or it's just there for a little while and then it slows down, what you can do is when your baby shuts down, so its eyes will shut, it'll stop suckling and it'll go to sleep. It's not asleep, it's just not getting flow. Babies that get flow have lovely big wide open eyes and they're really glugging. And so babies with low supply don't, on the converse of that. So in order to increase that, you do your compressions first, and when the baby shuts down, eyes shut, it stops suckling, you swap to the other side, and that's often hand in hand with very sore nipples. We know that, and it's really hard, and you have to be very brave to keep taking your baby off the breast and putting it back on the other side. But we switch, and then you go back to that when your baby's fallen asleep again, and then you go back to that side, and you go back to that side, and you go back to that side, and you're doing your compressions, and you go back to that side. It's a great tool without having too much equipment. You go back to that side, you keep going back to that side, and you give as many rounds as you can to that baby, and certainly do it for 48 hours to 72 hours, so 2 to 4 days. You do your switching and your compressing, and that might be all you need to do to start with, to increase your baby's flow and to start to wake it up a little bit more. And babies that are a little bit early are very good at that. So switch, compress, switch, compress, switch, compress. That will encourage babies to wake up and start to transfer milk a bit better. And then you start to see that after 48 to 72 hours, your baby will start to feed for longer before you switch it. And that's the first sign after 2 days that the milk production has gone up a little bit. And you start to see that nappies are a bit heavier, you start to see the nappies are a bit more yellow, and also your baby's going longer between feeds. It's not hungry all the time. And if you can do that, you might even get away without having to pump. So you can try your switch and compression first, then you can then introduce pumping afterwards, which is a real challenge. It's the hardest thing you'll have to do with everything else, is to just this constant circle of triple feeding. So that's breastfeeding, pumping, and then topping your baby up afterwards. But sometimes that has to be done. And we say if you do 8 pumps a day in 24 hours for a good, for 2 weeks, instead of 4 pumps a day for 6 weeks. It's much harder to do 2 weeks, but it's short and sharp, and it really works very effectively. You can be dribbling along, and you can just do a little bit of pumping every day, and it'll take you weeks and weeks and weeks to build a supply up, and it's very tiring. It does grind you down. So you've got to see the end of this when you're having to do that. If your baby's not gaining enough weight, you've got to see that it's going to stop, and that you're going to get out and have a nice life with your baby, because it's absolutely exhausting. And we know that you're tired, we know that, we know how hard you're working, and there is no, there's nothing to say that it's not hard. It is really, really hard, but you get payback, and if you do it to the dot, If you do lots of pumping, lots of skin to skin, switching and compressing, and you top your baby up, you start to increase your supply and your baby's skills start to improve. And that, that's how we would increase milk supply. There isn't anything magical that you can do to make milk. It's about transferring it, and it's about stimulating your breasts. I don't know if you want to talk through a little bit of pumping.
Yeah, you can
just
do.
To go through the pumping.
Emma came back and asked where can she get the syringes from. If your midwives aren't able to get them to you, you can obviously contact us. Yara, contact details are on the maternity website, and we can pop a few in the post to you if you want to do that. But it doesn't have to be a syringe. I mean, we tend to use syringes here in the hospital for collecting colostrum. It doesn't have to be a syringe. It could be anything. It could be an ice cube holder, that then goes in the freezer. But it can be anything really. I mean, we've got these little pots that we have. We don't have many of those. Those are sort of samples that we have, little colostrum pots.
Well, you can find your own.
Anything small.
Doesn't matter, as long as it's clean.
Yeah.
Soapy warm water, it's clean, you can collect in it. And you're unlikely to fill one of those, just saying. Right? You're unlikely to fill one of those, but some people do, but you're unlikely to. So just saying, the expectation is, a couple of notches on that and a few glistens. So don't think that that's what we're expecting you to produce, all right?
And because how much does the blue one hold?
Oh my God,
quite a lot, I think.
It's about 15 mils.
Yes,
I think.
that's a huge amount.
It's a large amount.
Whereas the syringes are 1 mil, and the majority of people when they start, if they get 0.1 or 0.2, we're delighted, and then that builds up, as Naomi said. The volumes keep building up. The more you do, the more you get. The more you ask for, the more you get. So it's this whole supply and demand thing. So did you want me to talk about pumping?
Yeah, so just in case that's what you have to do as the next level, and you certainly don't have to have a pump if you're breastfeeding. It's not something that you have to go out and buy. We do have pumps on loan that each community midwife group usually has a little supply of pumps that they only loan them out for a week at a time, so they're coming and going all the time. So the chances are you probably will get one from your local midwifery team. And if you can't get one from them, then we will, we can go around, your midwife can go around and see if she can source one from another team if it's urgent. So we don't give them out in the hospital, unfortunately. We have got them in the hospital, but we don't give them out in the hospital for community. But your community teams do, and so do the health visitors. They also have access to loaning out pumps too. So, that might tide you over until you can source one yourself if that's what you want, but you don't have to go and buy one. So don't rush out and buy the first one you see in the shops, because it might not be the one that works very well. Have a think about what your needs are with the pump and what you want to be doing with it, and what you have to use it for. If you've got problems, you need one that's going to be reasonably good if you're having some breastfeeding problems, and that might be that you loan one from you get one loaned from the teams that you work with.
Yeah, many women spend their whole breastfeeding journeys and never ever pump, and they do just fine. So those mums that do end up pumping, we tend to use here in the hospital double pumps. So once they're producing more than colostrum, so usually what we're looking for, that there's more in volume, it's lighter in colour, and it's less sticky, because colostrum is really sticky. I've already said it's a bit like golden syrup, and it becomes less and less like that. It just begins to pour more. It doesn't just collect in droplets. So you really see that change. So we wouldn't normally think about using a pump until a woman's or what we call transitional milk. So this milk is changing. It's usually lighter, as I say, lighter in colour, more volume, and less sticky. So thank you, Emma. She said thank you already. It's very quick.
Good.
So that's when we would be thinking about a pump. We tend to use double pumps because the one thing your breasts do together is let down. They work totally autonomously otherwise. So women who have problems with one, so we have occasionally have a woman who might have a recurrent mastitis, or she may have had surgery on one breast. She can actually produce enough milk in the other breast, and they work independently. So you can have one non-lactating and one lactating breast. But obviously we assume initially that most women will be producing milk from both breasts. And because the oxytocin works on both and causes the letdown in both breasts, double pumping usually means that you spend slightly less time pumping, but for more milk in the sort of the end result. So this is a typical pump kit that fits with an Amida or Calypso type pump, so Amida or Ardo pumps we have here in the hospital, and we tend to suggest that mums hold it between their fingers and thumbs, so fingers like that, yeah, and that she uses her the rest of her hand to hold it onto the breast. So she'd hold it on in this position. That leaves some contact with the hands on the breast. And we would always start the pump in the way a baby starts. So we start with fast cycles and lowish vacuum. So it depends on the pump as to how the settings are set, but it would be fast cycles, low vacuum, because babies always go to the breast, as Naomi's been talking about, that suck, swallow, pant, and they go chomp, 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 waiting for the letdown. The letdown happens and they go into big, deep sucks with pauses. So a mum will watch and look down the funnels, and when she starts to see milk coming, she'll slow the pump right down and up the vacuum to wherever is comfortable. Now, that does not need to be full blast, because actually you can do an awful lot of damage with a pump. It just needs to be enough to keep the milk moving and get the milk removed. So we're not looking at full on. Some women put full on and it doesn't bother them, but other women may only go 1/3 across on the dial, and that's enough for them. As long as the milk is coming, it doesn't matter.
And you might not feel your letdown. Most
Yeah,
women don't
some
feel their
women
letdown, so don't wait for it and think, well, I haven't
Yeah.
let down. Some women get really tingly and feeling pressure in their backs and all sorts, but most women don't feel their letdown. So don't be alarmed if you don't, because that's also normal.
Yeah.
But you will see it.
You'll see
You'll
it.
see
You'll
your
see the
baby
milk
suckling
coming.
more, or you'll see the milk in the pump more.
Yeah. So they'll see the milk coming. And then we try to be as hands-on as possible, and we often recommend mothers go and look at Stanford University Maximising Milk Supply, which is a wonderful 9-minute video showing women really using their hands on the breast, and they do fantastically to get good volumes of milk. And we get all our mothers to have a look at that who are trying to push their milk supply. So we would highly recommend that hands are on the breast. You're not holding the bottle, you're holding the flange onto the breast, and that allows the mother to have that tactile touch with the breast, because that helps the stimulation. She watches the milk coming, and it's going nice and slow, and the pump's going nice and slow, and she should see it dolloping, it'll come down into the bottle, and it's going to vary tremendously woman to woman, time to time that she's doing, how much she gets. But when it starts to slow or stop, we would say have a break. It could be that they just flip the kits off, releasing the vacuum with their thumb, flip the kits off, have a 30-second break, start again, just put it back on again, and off they go again. And they'll get another letdown, regardless of whether they feel it. It will happen, because that's what happens when babies are at the breast. Babies feed and pause and feed and pause, and when they start again, and after those pauses, they get a second letdown, a third letdown, a fourth letdown. So when women sit there and pump just that first initial letdown, they're actually leaving the second, the third, the fourth, the fifth letdown in the breast, and they're not pushing their milk supplies. They could be getting more. We would anticipate each time the pump kit is put back on, she'll get a bit less than she did the first time, but each time she's putting that order in for more milk. So we would normally say to mums doing it sort of 3 or so times on each breast. So setting the pump up, go until the milk starts to slow or stop, having a 30-second break, start again, until it starts to slow or stop, flipping the kits off again, start again. And then, if possible, getting their hands on the breast. Some women choose to cut up an old bra and post the kits through the bra so they have hands free, and they can get their hands on the breast and they can massage and compress while they're pumping, because that makes a huge difference. Others cut up an old piece of tubey grip, and we have tubey grip here we can help with. And some people will choose to do 2 together, maybe 1, and get their hands all over the breast, 1, hands all over the breast, back to 2, and then hand express at the end. So these are the ways that we would normally recommend mothers to really push their milk supply, because that's what, as Naomi said earlier, from day 3 to 2 weeks is that window of opportunity to really push that milk supply. You're laying the foundations for that whole lactation. This whole lactation until you and your baby decide to stop feeding is set at this period of time, and it's very difficult to influence it later. So the more you can do in these early days, the better it's going to be overall.
Then you've got choice. If
Yes.
you don't do it, you don't have choice. So you
Yeah.
might choose not to breastfeed for very long, but you've got the choice. And you may choose to, not breastfeed every feed, but you've got the choice. You can increase, if you do then decide you want to go back to breastfeeding, you have the choice. And certainly with the COVID pandemic, we are encouraging mums to give breast milk every day to their babies, even if they're thinking about giving up, to just encouraging them to do at least 1 feed a day of breast milk, just to protect your babies with the viral protection. And the research that has come out this week that actually there is COVID antibodies in breast milk to protect the babies. They've actually now found that that's happening. So, if you are thinking of stopping, really consider the next few months as to what's happening with this pandemic, to protect your baby with its viral load while you're breastfeeding, and the impact of giving breast milk to your baby, even if it's only one small amount a day, it's going to offer that baby protection with the antibodies. So that's how we would suggest. There isn't anything magic that we can give you that will increase your milk supply other than absolute hard work, and it's short, sharp, sudden, but effective. But you know, we would like to think that we would not have to do that as the first thing. We would like to say that on day 3, when you're not quite achieving what we're expecting you to do, that you seek help and you ask somebody to support you in breastfeeding and get some good positioning and attachment support. So that's with your healthcare professionals, and also OBS, the Oxfordshire Breastfeeding Support. They're doing breastfeeding support every day, and also La Leche League, and you know, the breastfeeding helplines, they're also available. So seek help early, because then you're going to put everything in place before you get to that large weight loss. So if we act early, you can turn it around much more quickly, and then you don't have to do such a lot of things in order to get that milk back, or to get that milk supply up, and to give that baby more food. You can stop it happening before it becomes a real problem. So be proactive as parents as well, and seek help and say you want some help breastfeeding, the baby is not pooing, and you don't think that the feeding is going as well as you thought. Don't wait to day 5 and find out that your baby's lost 11 or 12%, because then you have to work so hard to get that back.
Right, we've actually got no more questions.
Fabulous.
And we've heard from the lovely Jane Joyce from OBS, Oxfordshire Breastfeeding Support, who are fantastic out there doing all their wonderful
Brilliant.
support in the community. So just thanking us for what we're doing, which is really nice. So
We'll thank you back.
Yeah, thank you from us too, for a good team effort we are. But, so I think we've done over an hour.
We have. And
hopefully it's been useful. Oh, and from the La Leche League as well.
Thank you.
What would we do with all that? And we're going to have to give a shout out for the Abingdon Baby Cafe as well, if we're going to do everybody.
Yes.
So
absolutely. And same time next week, I think.
Yeah.
Think of your questions, anything you would like to ask us, and we'll have more. Okay. Lovely to see you all.
Thank you very
Thank you
much.
for coming. Bye.
Bye.